Well, it's certainly been a complicated and difficult year for all of us, and certainly our myeloma patients are no exception. Uh, Caring for patients has completely changed how we approach our day-to-day work, and we've attempted to keep our patients safe while maintaining disease control and keep our facilities clear of COVID. It's been an enormous challenge and one that's evolved significantly over the past year. At the beginning of the pandemic, we essentially locked down our institute. We did continue treatment for our patients with the goal of minimizing their exposure to the hospital and clinics. And then following the outbreaks in Seattle and New York, we completely shut down the myeloma transplant program, including both our in and outpatient transplants, for about a month before we reopened to only the inpatient procedures. At that time, all non-essential staff worked from home. We minimized the total number of people in the hospital, and all precautions were taken, including screening everyone that walked into the institute with temperature checks and mandatory masking. I was proud of the work that we did. We were proactive, we were flexible, and we were able to keep COVID out of the Huntsman. Ultimately, this allowed us the confidence to continue treating our patients with our standard of care protocols and also on clinical trials. I think we've been largely very successful navigating the past year. We've certainly had patients that have died as a result of COVID, but the number's been pretty small and occurred only in those patients with significant comorbidities like kidney and lung disease. Largely, I believe the diligence of our patients and the staff to remain safe was instrumental in our ability to successfully navigate the past year. So now as we turn over the new year, we have this hope of the vaccines. People have grown accustomed to masking and distancing, and overall, it's allowed us to reopen the doors, though with continued restrictions like limited visitor policy. We do continue to treat our patients on a routine basis. We've restarted all of our autologous transplants, both in and outpatient. Patients are now returning for in-person visits, and we continue to enroll in clinical trials. I think the biggest changes that we've made, I believe, are changes that should have probably happened years ago anyway. We're now able to do telemedicine, visiting with and keeping an eye on patients not only in the Salt Lake City area, but also patients in surrounding states. Additionally, we've made some fundamental changes in our delivery of treatments, as we're now treating our patients with weekly proteasome inhibitors and subcutaneous daratumumab, all in an effort to decrease their exposure to the healthcare setting. And the challenge now, I believe, is that we must remain vigilant. All patients and staff are being vaccinated, and we expect that everyone continue to mask and practice good hand hygiene and social distancing. The shift to virtual visits has really revolutionized how we monitor our patients, and it's been the single biggest blessing of this pandemic. Our catchment area spans 8 states. And prior to the pandemic, our patients would have to travel great distances to see us. So now we're able to routinely see patients that we previously had a hard time seeing. The patients love it, so do we. But virtual visits aren't without their problems. I think sadly, the technology is far behind and oftentimes makes it difficult to have a full visit without connectivity or platform related issues. Also, our patient population is older, so in many cases, they don't have the cell phones or the computer savviness to connect with us. And lastly, our ability to have virtual visits is limited by our ability to maintain emergency licensure in our surrounding states. In my mind, this is a service that should be allowed to cross state lines and is an advancement that we should hold on to after the pandemic is over. I will say on a more personal note, virtual visits do make doctoring more difficult. One of the most important parts of our practice is to sit in front of the patients, perform our physical exams, and just develop a personal connection. And this is harder to do virtually, and honestly, I very much miss it. I think it's imperative that all of our patients are vaccinated as soon as possible. Based on the biology of the disease and our treatments, our patients are immunocompromised, and anything that we do to protect them is an absolute must. While we don't yet know whether our patients will have a robust antibody response or whether certain treatments will impair a sufficient response to the vaccines, I do believe that this should not stand in the way of our people being vaccinated. Here at the Huntsman, in general, we're following the International Myeloma Society guidelines. I do think it's important to point out a number of important points from those guidelines. So number one, we vaccinate as soon as possible. 2, if patients have active or progressive disease, treatment should continue and patients should be vaccinated. 3, patients undergoing autologous transplant or CAR T therapy should have their vaccination process start within about 90 days after cell infusion. 4, patients on Revlimid maintenance should be vaccinated without interruption of their treatment. And for patients on trial, vaccination is generally allowable, though it's trial specific. And then lastly, in those patients on any other treatment other than Revlimid maintenance, if possible, drugs should be held from 1 week before the first vaccine until 1 week after the second dose. While this may not be feasible for the majority of our patients to hold treatment for up to 6 weeks, we should say at the very least, we consider a multi-week treatment interval during the vaccination process.